about pharmacology and some therapies that will, pharmacology is one of the common ways that we treat lots of different illnesses. So before we get into a long list of specific illnesses, which is pretty much the rest of the course after this, I thought we would talk, or we'd cover Chapter 16, which just is sort of intro to pharmacology. Who has had pharmacology in one form or another already? Okay, so for a few of you, this will be some review. But it's a good refresher anyway. We're going to talk about it very generally, not going to talk about specific meds and stuff at all. All right. So pharmacology, by definition, is the study of medications, which includes their actions, their doses, their uses, their adverse effects, their interactions. I mean, pretty much anything about medications themselves fall into pharmacology. Drugs come from a variety of different sources. More and more these days, drugs are totally synthesized in the laboratory. Now, oftentimes they use some kind of a natural model. In other words, back before there was complex chemistry like we have today, most of the medicines that were used to treat the sick or wounded were literally taken right from natural sources. The sap of plants, leaves, fungi of different kinds. So people were very creative about finding sources of medications out in the environment. So a lot of medicines are modeled after those natural compounds and then improved somehow, to make them better or more effective. So drugs get used in lots of different ways. I mean, this is not an exhaustive list, but there are lots of ways medications are used. So we're not going to get into that part of it. So the therapeutic effect that you're after can result from many different interactions. I mean, I think the simplest way to think about it is all medications at some point have to interact with cells in order to do anything, because it's cells that generate the inflammatory response. It's cells that are essentially doing all of the work, whether it's in a normal state or whether it's in a disease state. So you can act on those cells in a stimulatory way, get them to do more, an inhibitory way, get them to do less, and with increasing commonality, we can get cells to do something different. In other words, we're not turning them up or turning them down, we're turning them sideways, so to speak. We're getting them to do something they wouldn't normally have done. There are a few medications that don't act on cells. Instead, they work either through basic physics or basic chemistry. So, for example, like sorbitol is a stool softener, and it doesn't work by any active means. It just pulls water into it because it has a high osmolar concentration. So, some medicines don't actually work on cells, but most do. Vocabulary, the indications of a drug are what that drug will treat. When should you use it, in other words? And many drugs have a long list of indications because they can be used in a variety of illnesses or disease states. Contraindications are when you shouldn't use a drug. So when you should and when you shouldn't use them. So these can be anything from risk factors to risk of cardiovascular collapse, if you apply two cardiovascular medicines in the same patient, for example, on some. Lots of medications have effects we don't want. One of the biggest places in research today is to try to find perfect medicines. In other words, they only do what we want them to do and they don't do anything else. But most of the medicines that are in the formulary that are available for use have some downside. So a side effect is an unintended effect. In other words, it's not something we were after, but it's tolerable for what we get out of giving the medication. So an example of this would be, we give a diuretic for high blood pressure, and the person complains of having to go to the bathroom all the time. Well, that's a side effect. That's kind of how the medicine works. So tolerable effects. Adverse or toxic effects start to show up. Adverse and then toxic is when the side effects or secondary effects start to outweigh the benefit of that medication in the first place. Toxic effects are when you stop the medicine. You consider the side effect to be causing more harm to the patient than the medication is doing good. There are lots of different kinds of adverse effects, some common ones. Hypersensitivity or allergic reaction. Particularly we find in the nature-derived medications that some people will be allergic. These are your penicillins, these are your sulfa drugs, and any medication that's based on those drugs can trigger allergic reaction, even a severe one like anaphylaxis. So hypersensitivity. Idiosyncratic. Human beings are a very diverse species. There are lots of different genes and lots of different patterns. So every once in a while, out of the blue, some patient will respond very differently to a medication for no known reason. What's the reason? Something about their genetic makeup makes them respond differently to this medicine. So one that I came across in pediatrics from time to time is Benadryl we often give as a mild sedative because it makes you sleepy. In some kids, it has the opposite effect. It wires them up instead. So that's a classic idiosyncratic reaction. You don't know that until you try it. So if you're going on a long trip with a kid, before you give them Benadryl in the car, give them Benadryl a couple of days before to see if they go nuts about it, just as a tip. Iatrogenic, this is an adverse effect that is medicine's fault. In other words, it's not the medicine itself, but some medication error, medication purity. That used to be a problem. It isn't anymore. Like penicillin in the World War II days was so expensive and so hard to come by that it was actually recovered from patients' urine after it was administered so that they could reuse the same penicillin. So we don't have those problems anymore, but it used to be an issue, medication purity. Teratogenic. Some medicines can cause harm to the developing fetus. We talked about teratogens and how they cause developmental abnormalities. One of the problems with medications in pregnancy is we don't always know which medicines cause problems and which don't. So as a general rule of thumb in obstetrics, you avoid all medicines as much as possible because of that unknown risk. And then interactions. Drugs are affecting cells. Cells are busy things. They do lots of different things. So different medications can interact in a variety of different ways. They can increase each other's effectiveness. Sometimes that's a good thing. We call that synergism, where 1 + 1 = 4. Sometimes that works in our favor, but only if we're expecting it. There are synergism examples in blood pressure medicines, for example. And if you give one medicine and it lowers their blood pressure 10 points, you give another medicine, it lowers another 10 points. If you combine those two, you may drop their pressure by 50 points because of how the medicines may interact. So synergism can also result in toxicity, where the medications themselves start causing problems. Certain antibiotics with certain diuretics, for example, can do that. Or the two medicines can decrease each other's effectiveness, so be antagonistic. One example of this is Narcan and morphine for pain. Narcan blocks the effect of morphine. So sometimes we can use antagonism as a rescue from an overdose, but if we're not aware of the interaction, we'll end up under-treating the patient because the medicines are blocking each other, essentially, or blocking each other's effect. There are lots of interactions. Now that people are living longer with more different diseases, the number of drugs that patients are on is always going up. Particularly in the elderly, they have sometimes 15 or 20 medications that they're on. So it has gone, figuring out interactions, you really need a pharmacist. You need a pharmacy doctor to help you manage those things unless you have a lot of experience with the medicines that you're using. Long gone are the days where we think we can predict all the interactions. There's just too many medicines out there used for too many different things. All right, so basic pharmacology follows the movement of a medicine through the patient's system. So in the end, all drugs have to do all of these things. So they have to be administered. In other words, they have to get into the patient, either into the mouth or to the veins. They have to be absorbed they have to get from whatever you gave them into the bloodstream in order to be distributed to the body. Well, they have to be absorbed, and then once they're in the blood, they get distributed. So move to the site of action. Usually, unless it's topical, we're not putting the medicine where we want it to work. We're putting it somewhere else. And then eventually that medication has to be removed. You know, there's no such thing as a medicine you can give once and it just stays there forever. At some point, it's either going to be broken down, metabolized, or it's going to be excreted, either through the kidney or through the liver and into the digestive tract. So all drugs have to go through those things. So here's that just, you know, in pictures. Typical oral ingestion, you know, it goes into the digestive tract. It's gradually absorbed into the bloodstream. There's always a little metabolism in the liver even before it gets anywhere else. We call that first pass metabolism. And a lot of medicines, for example, like amoxicillin, you give quite literally twice the dose you need in the blood because so much of it is destroyed by the liver before it even gets anywhere. Other methods of routes of administration, intramuscular injection eventually gets into the bloodstream as it leaks out of the interstitial fluid in the muscle into the blood. Intravenous injection assures absorption. You know, in other words, it's going to get into the blood because you're putting it right into the blood. So this is the widest group of medications because if you're putting it into the blood, if you can make it, you can put it into the blood, basically. But not all substances can survive the digestive tract. So oral medications, there's many fewer of those than there are intravenous medications for that reason. So, and then eventually the liver or the kidney is going to excrete those. All right. So the goal of medication dosing, it's all about therapeutic level. So too much of a drug is going to cause problems. Too little of a drug in the bloodstream is not going to do anything at all. So what we're always looking for is to keep that medication as close to the therapeutic level as possible while staying well below the toxic range. So the way we do this is by changing the dose or the timing or both to try to match that therapeutic level. And what I mean by therapeutic level is this is the level in the blood, the concentration in the blood where the medication is going to do its job and is not going to cause any overdose side effects or any toxic side effects. So this is sort of what we're after. Now, you can't really do this unless the patient is on a drip. You know, unless you're putting a little bit of medication into their blood all the time, you're never going to achieve this perfect, you know, effective therapeutic level, you know, locked in. Instead, we dose patients. You know, we give a medicine 3 times a day or twice a day or 4 times a day. So because of that, we're always going to have ups and downs. But what we want to see is, you know, if this is the therapeutic level right here, and this is the toxic or unsafe level, and this, you know, it has to be above the therapeutic level to work, we want to have a dosing regimen that kind of goes along like this. You know, so as the level starts to fall below therapeutic, you know, that's a dose. So we're going to give them more medicine, the level's going to go up, you know, and then that's another dose. So this is sort of the ideal in a dosing regimen, you know, not a steady state like you see there. Now, sometimes our patients don't follow our directions and they do their own thing. And you can get into real problems with that. So like here is an example where the patient is taking too much medicine too infrequently. So they take the medicine, you know, and they shoot up to above the unsafe region, and then eventually that falls off, and now they're too low. So they not only have gaps in their effective level, but they also have unsafe levels as well. So in this case, you'd want to give less medicine more frequently to try to get that, you know, level up here between effective and unsafe. Here's an example of taking twice the dose or too frequently of a dose. So what do you have here? Now we're unsafe level the whole time. We don't want that either. Many drugs in their toxic state damage the kidney or liver, because the kidney and liver are what take care of anything that's unnatural in the body. You know, medicines certainly fall into that category. So they tend to do their damage up here. All right. So medications are studied in that, you know, there's multiple phases of research that go into releasing a new medicine. In the first phase is where they do what are called pharmacodynamics. And that is, how well is the medicine absorbed? You know, what dose given to a patient achieves a therapeutic level? Basically, the curves are learned about, so that by the time a medicine is being tested for effectiveness, we already know what the dosing should be. You know, the dosing to keep the level above therapeutic but below toxicity. So that's all done in early clinical trials. But not all patients are the same, and oftentimes sick patients have factors that affect how drugs are absorbed or how drugs are excreted. So we sometimes have to tailor our drug dosing and times and doses to the individual patient. Because, for example, if they are in heart failure, their circulation is poor, so they're going to excrete that drug less well. So we're going to have to give them less medicine less often. Body weight and fatty tissue. Some medications dissolve in lipids, so the more adipose tissue you have, the bigger the dose you need. Steroids can be like that because steroids dissolve in fat. So sometimes the very obese patient needs much more steroids because it's getting distributed differently than in somebody of a normal weight. And then, you know, GI problems, liver problems, kidney problems can affect either absorption, metabolism, or excretion. So all that to say, we sometimes have to tailor medicine dosing to the patient. Now, when that is particularly important is when the toxic level is very close to the therapeutic level. Because when this is the case, you don't have much room for individual variation. Most medications, you know, it's like this. The therapeutic level is much, much, much lower than the toxic level. But for medicines, a great example of this is gentamicin, which is an antibiotic. It's toxic to the kidney at not very high above its therapeutic level. So what we do in those cases where we've got a dangerous medicine and a patient we're not sure how well they're metabolizing or absorbing is we actually check the levels of the drug in the blood. So that way we can tune our dosing specifically to that patient. And you see this done in medications that have some known toxicity. You know, so gentamicin, for example, dilantin is another one where too much is bad. Coumadin is another. Digoxin is a third. So there are a number of these medicines where when you first start the patient on it, you'll end up checking their blood levels of that at various times through the dosing curve to make sure that we're out of toxic range but still therapeutic.
So why did you check like the vancomycin? Is it the same reason?
It's the same thing. It affects the kidney at high levels. And some people, you know, not like we just said, not everybody metabolizes it in the same way. So particularly antibiotics can be dangerous at high levels, so it's the same thing, same reason. And to make sure that we're above therapeutic levels too. There's no point in giving vanco down here because all you're doing is making resistant bacteria. So you want to make sure it's high enough too. Yeah. So there are, like we saw, lots of different routes: intravenous, intramuscular, sublingual, PO. Each of these different routes has advantages and disadvantages. You know, PO in some ways is the most convenient route to go, but that means that the medicine has to endure the digestive tract before it can actually do anything, which not very many medicines can. I know you cover routes of administration in some of your other classes, so you know, we're not going to get into too much detail about that, but there is a table in your book that's all about administration and the upsides and downsides to each one. All right. So we've got the drug into the patient. We've got it at a therapeutic level. You know, what are some of the ways that these medications actually do their thing? Well, a very common class of medicine in use today are receptor-based medicines, where their action is going to be determined by their effects on a cell's receptor to a chemical. So they can be either agonists, they can turn that receptor on, trigger that cell's response to whatever that receptor is for, or they can be antagonistic, they block the receptor. So we talk about agonists, and sometimes we just talk about blockers, but an antagonist is a blocker. So some examples: the beta blockers block the beta 2 or beta 1 receptor on the heart cells, so it effectively blocks the sympathetic nervous system's effects on the heart. Alpha agonists are used, they're sort of the opposite. They activate alpha receptors at certain sites in the body. So like alpha agonists are used to shrink the prostate gland. They can also be used to elevate blood pressure. Epinephrine is both a beta and alpha agonist, so it activates both of those. Many of you will have heard of calcium channel blockers. This isn't really a receptor, but it acts in the same way. It blocks the calcium channels, which means less calcium gets into the smooth muscle and arteries, so they relax and blood pressure goes down. So agonistic and antagonistic at receptors or channels. Other medications work on proteins that sit somewhere in the metabolic pathway. So like the ACE inhibitor, this is the angiotensin converting enzyme inhibitor, and it does just what it says. The angiotensin converting enzyme turns angiotensin 1 into angiotensin 2. Angiotensin 2 causes all kinds of high blood pressure effects. So if we turn off that converting enzyme, we don't have the angiotensin 2, so we don't have the high blood pressure effects. So all that to say, acts on proteins to change the metabolism towards one way or towards another. So this top one, this would be an agonist. So here's our medication. It attaches to the receptor of a cell, and it activates that cell. So it behaves just like whatever that receptor is supposed to be for. So like in the heart, the beta 1 adrenergic receptor is supposed to respond to epinephrine or adrenaline or noradrenaline. But we can give a beta agonist, and it will behave like the same thing. So it would speed up the heart, for example. This is an antagonist. One way the antagonists work is they block a site. So drug number 2 clicks in here, and now the original chemical that would have activated this receptor can't get to that receptor because it's blocked. So this would be like a beta blocker or a calcium channel blocker. So antagonism and agonism. All right. Again, prescription and orders are not part of this course either, but it is important to know when talking about medicines, all medicines have 3 names. 2 get used interchangeably, particularly when a medicine has been out for a long time, and the 3rd is never ever used in the hospital. So the generic name, there's an international organization of pharmacopoeia. In other words, it's all about medicines. And medicines or companies petition for a generic name. They give suggestions, but in the end, it's this international body that decides what the generic name is going to be. So some examples: diazepam, ibuprofen, hydrochlorothiazide. So those are the generic names. The different companies that make these drugs can give them their own names, and very often the trade names are sort of advertising. They often say something about what the medicine does, or they say something about what they want you to think it does, because in the end it's like a brand name, essentially. So like diazepam is also called Valium, Vivol, Diastat. All of those things are diazepam. Like ibuprofen, half of the pills at the pain relief counter in the drugstore are ibuprofen, but they all have different names. So Advil, Motrin, Ibrin. Same with hydrochlorothiazide. And then the chemical name, the only people who would ever use these are organic chemists, who either are describing this particular molecule or are doing some part in the making of it. So you will never see in a chart this big, long, nasty thing that just is, we call it diazepam instead. All right. So in addition to pharmaceuticals, and this is really growing in commonality. You know, we had a phase where we didn't have very many medicines we could use, you know, in the 1800s, 1800s. So there weren't very many medicines. Then in the 1900s and, you know, into the current century, there are lots of medicines that do lots of different things, so we use a lot of medicines. And now in the last 20 years, we've started to try to do other things besides just medications to help people. So typically, and all of you who will work in healthcare anyway, are going to be part of a team that's treating the patient. You know, and part of the other members of the team are going to be people who are providing therapies. In other words, not medications, but still helping the patient get better or helping the patient recover using other approaches. So a physiotherapist, occupational therapist, speech-language pathologist. Nutrition, there's a growing understanding of the importance of nutrition in patient care and patient well-being and patient healing and positive outcomes. So in many hospitals, a nutrition consult is mandatory once the patient has been there for more than a couple of days, let's say. And that's a good thing. You know, that way we know that the patient is getting all of the nutrition that they need. And then there's a set of therapies, they call them complementary therapies, because they really wouldn't solve the problem themselves. In other words, these are not curative, like some of those therapies we just looked at. They help the patient get better. They're not going to make the patient better all by themselves. And here again, particularly in the last 10 to 20 years, there's been, you know, a growing interest in America in some of these alternative or complementary therapies. This is also called alternative therapies in some older texts. So this is things like osteopathy, chiropractors, massage, touch, herbal medicines. You know, there's aromatherapy, music therapy. I mean, there's lots of these things. And you could include things like acupuncture as well, and some of the Eastern traditional medicines are, you know, being used as therapies in addition to our typical Western medicine therapies too. Your book goes into a lot of details about these things, but because I have like very little knowledge of any of them, I just kind of say they're there. And you can look and see what's in the book there about them. Okay, so which is the route of... Oh, wait, first, student number question. What?
I said I would never bring my thing. I don't know what I keep I'm back.
So get logged in. Oh, I didn't put the number up. 42, 33, 42, right? Or you can share.
She can use that and I'll use this. You go, did you open that question up though?
The student number questions should be up.
Yeah.
No, I haven't done this one yet.
Oh.
I'm still waiting. Because I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 people in the room and 9 people in the room on my computer. Have you put yours in yet, Carolyn, your number?
No.
You're the 10th then.
See, I did this yesterday, but I did this yesterday. Oh, put me as a teacher because I have to do this.
All right, I'm going to move ahead, Carolyn.
Yeah, go ahead.
Okay.
I got an A.
Okay, so here's the question. Which is the route of administration by which the largest proportion of the drug is likely lost before reaching the site of action? So where is there the biggest loss?
Oh, I let you know how to answer it, sorry.
All right, that's everybody. And good, almost all of you got that. That's oral. And the reason for that is the liver. All of the blood from the small and large intestine and the stomach passes through the liver before it goes anywhere else in the body. The liver is the great metabolizer. It takes just about anything that the body didn't make itself and destroys that chemical. It alters it, changes it, breaks it down. So a lot of times it's 50% or more of the oral dose is destroyed by the liver before it ever goes anywhere else. So that's that first pass metabolism. And it's the reason why typically oral dosing is much higher than IV dosing. You know, you would never think of giving IV doses at the same level as oral doses, and it's because the liver cuts it in half before it goes anywhere else. These others go directly into the bloodstream and bypass the liver. So one of the reasons that sublingual is used as a delivery method is the veins that drain the mouth don't pass through the liver before they go to the rest of the body. So like nitroglycerin is often given this way, absorbed right into the vessels in the mucosa under the tongue. Vitamin B12 can be given this way too for that same reason. And then IM and IV go right into the blood, so very little is lost. All right, which of these describes an interaction of two drugs that produces a greater effect than the sum?
Can I ask you a question about our homework while we're waiting?
Sure.
If I did this, it thinks I'm a teacher. I don't know how to change this. I don't know.
Is it asking you for a login?
It gave me a room number and it wants, yeah. It's just a login. Like, I entered my,
Go to M. It's M.
That's what I'm messing up. That's what.
m.socrative.com.
Okay. This question is worded funny though. It's what is the term used to describe the degree of pain that is endured before an individual takes action?
That's pain tolerance.
That's what we thought, but it says before they take action.
Before they take action. In other words, how much pain do they endure before they do something about it? That's pain tolerance.
I just wanted to make sure we weren't reading it weird.
Pain threshold is when you become aware that you're having pain, not doing anything with it. You're finally in. There we go. Okay, so that's synergism. Synergism is where you take, a medicine that would have had, an effect of 2 and a medicine that would have had an effect of 2, and you get 5 or 6 or 10 out of it. All right. So that was pharmacology in a nutshell. And as we'll see, medications play a role in lots of different diseases and their treatments. All right. So let me get going. So chapter 17, we start in on what is now going to be the rest of the course. And that is, we're going to go through sort of system by system, looking at common disorders that occur in these various systems. Now, what I found teaching this class in the past, this is now my 3rd time teaching this, is we don't have enough time to go into the detail I would love to go into about these disorders. So what you're going to find is many of the slide sets on Angel, I'll have shortened them a great deal for class. Now, I'm only going to test you on the shortened versions, okay? I should be able to get the updated ones up onto Angel at some point, but just to let you know that they're smaller than what you might have seen already. And this is one of those, and you'll just see as we get into it that that's what has to happen. All right, so blood disorders. This is a very old term, blood dyscrasias, but that's what your book uses. Nobody uses that word anymore, dyscrasias. They'll call it what it is instead. But essentially, these are just blood problems. So we're going to start out with anemia. And, we've all heard that the definition of anemia is, your blood is too thin. Well, that's not going to cut it for, a pathophysiology discussion. So anemia is a reduction in oxygen carrying capacity. Now, the most common reason for that is you don't have enough red blood cells or your red blood cells don't have enough hemoglobin to carry enough oxygen around. But anemia, by definition, is a reduction in oxygen carrying capacity or oxygen transportation. So when the cells of the body aren't getting enough oxygen, the effects are sort of predictable. There's going to be a reduction in energy production, because oxygen is necessary to make ATP in the mitochondria. The body is going to see that oxygen deficit, and it's going to respond the way it usually does. Anytime that there's not enough oxygen in the blood, like say you suddenly got up and started running up and down the hallways, your oxygen level in the blood would drop, because you're using up more oxygen. The response to that is tachycardia, vasoconstriction, and increased respiratory rate. So in anemia, you're going to see that as the steady state. So people are going to have high pulse rates. They might look a little pale because they're vasoconstricted to try to elevate their blood pressure. Even though their blood pressure can be adequate, if the oxygen isn't there, the body responds as though it isn't. And then you see the classic signs of anemia. So fatigue, pallor, dyspnea, that increased effort to breathe, that's the body's response to not enough oxygen. It's trying to bring more oxygen in. The problem is there isn't anything to carry it around. So the dyspnea or the tachypnea doesn't really help you at all. Cold intolerance, irritability, delayed healing, and then that tachycardia. When this goes on for a long time, it can cause problems in the very active cells of the body. So in the CNS, that's where we get the fatigue. Not enough oxygen means a sluggish brain. Well, in the digestive tract, the epithelial cells are the busy cells, and when they don't get enough oxygen, they get inflamed, they get ulcerated, they kind of fall apart, so it can lead to digestive tract ulcers and diarrhea and things like that. Severe anemia, you can get angina with exertion. Again, angina is chest pain from the heart not getting enough oxygen. If the blood isn't carrying enough oxygen, well, there's no way for the oxygen to get to the heart. So you can get that angina. So we divide anemias into two big categories. There's the anemias. There's too few red blood cells, or red blood cells are dying. So that's the two big categories. You're either not making enough, or the ones you're making aren't functional, or your red blood cells are dying faster than they can be remade, or they're dying at an increased rate. So we're going to talk about this section first, and then we'll get to this section in sickle cell disease and thalassemia. All right, and this is where I changed some slides, so just be patient. It is the very same information. I have just restructured it so I can get through it quicker and not repeat myself as much, okay? So on this side, you've got your iron deficiency. That's the most common kind of anemia. Now, that iron deficiency can be just plain dietary. In other words, the patient is not taking in enough iron to meet their red blood cell demand. Or it can be from chronic blood loss. Losing blood is losing iron, and the body, when that isn't the case, recycles iron very efficiently. So if you're losing blood on a regular basis, you will get iron deficient unless you are taking in huge amounts of iron to offset that. There's the megaloblastic anemia or pernicious anemia. This is vitamin 12 deficiency, and it means that red blood cells don't form correctly. So they end up abnormal, and they don't carry as much oxygen as they should. In aplastic anemia, the problem is that the bone marrow isn't making red blood cells. There are a variety of causes for that. And then we'll talk about two kinds of hemolytic anemias where the red blood cells are dying, and that's thalassemia and sickle cell disease. All right. So iron deficiency anemia, it sort of gives its etiology is right there in its name. There is insufficient iron to produce normal amounts of hemoglobin. So you hopefully remember that hemoglobin is a protein made of 4 smaller proteins, and in the middle of that is, in each one of those subunits, is a heme molecule. That heme molecule has an iron in the middle. And it's the iron that does the work, and that is carrying oxygen around the body. Oxygen is highly reactive, O2 is. So we need this giant iron atom to grab hold of the O2 molecule so it can be hauled around the body. So the classic iron deficiency anemia is microcytic hypochromic. So what do those words mean? Microcytic means small cells. So these are red blood cells that are too small, and they're hypochromic, not or below colored. Chroma, like chroma as color, hypo below. So these are not red enough. In other words, they don't have adequate hemoglobin. So microcytic hypochromic anemia is iron deficiency, until proven otherwise anyway. So the causes can be broken down into these four. So insufficient intake. We don't need very much iron because our body recycles it so well, but we do need a little. Now, in most people's normal diets, particularly here in America, where so many things are iron fortified, like flour and cereal and bread and stuff like that, we don't see as much of this. In other countries, you see a lot of it because iron is fairly hard to find out there in the environment, particularly in people who have a high carbohydrate diet. In places where famine has occurred, rice has calories, for example, but it doesn't have very much anything else. So you get into dietary iron deficiencies. More common, I think, in this country is increased losses. So you've got some bleeding somewhere that you don't know about. So in the digestive tract, particularly heavy menses and women can do this. The iron lost is greater than the iron that's taken in the usual diet. Absorption issues can come up. Iron has to get from the food into the blood. And then reduced utilization, which is the least common of those things. All right. So because there are these other reasons, it is never appropriate to just say, okay, it's a microcytic hypochromic anemia, it's iron deficiency, take your, here's a vitamin supplement, here's an iron supplement, follow up in a year. Not good enough. You have to make sure that there's not a bleed somewhere, particularly in the GI tract, because most bleeding you're aware of, but bleeding high in the GI tract, the blood gets digested before it, leaves the patient, so it's very hard to identify. So it's one of the reasons we do the guaiac test. We have patients smear a little feces on a little card, then we develop it, and if it turns blue, that's a sign that there's blood there. That's why we do that, is looking for an occult bleed. All right. So here is the normal. Here's iron in the diet. Notice that only 10 to 15% of the iron that enters the mouth gets absorbed or can get absorbed. So like when you go to give an iron supplement, you don't give the patient just what they need, you give them 10 times more because that's all that gets absorbed. In the blood, that iron is moved around by transferrin, which takes it to the liver, and then the liver stores iron for us. So let's say you had a high iron diet for a while, and then you haven't had much iron. The liver stores iron for when we need it. So you only see iron deficiency anemia come up when the liver's sort of out, when it doesn't have any left to put into hemoglobin. So the liver transfers it to the bone marrow turns it into hemoglobin, and then we get into circulating blood. Blood cells usually live 120 days. Eventually they pop open, release their hemoglobin. The globin, the protein part, is recycled. The heme is broken into the iron and the bilirubin, and then the iron is recycled back here. So we have this circular pattern. All we have to replace is the amount of iron that doesn't get recycled. And in one of my other classes, I think it's 85% of the iron from red blood cells is recycled on a regular basis. So that's pretty efficient in terms of not needing a lot of iron in our diets. If we have chronic bleeding, though, the hemoglobin leaves the body, so it can't be recycled. The iron can't be brought back into the system. So we get decreased iron recycling and eventually red blood cells with decreased hemoglobin in them. All right. In addition to inadequate intake, iron needs acid present to be absorbed. So if you have a condition where the stomach is not producing adequate acid, one example of that is pretty rare, but it's achlorhydria, and it's an autoimmune disease of the stomach. But I sometimes wonder about, we treat gastroesophageal reflux disease with acid blockers, and I wonder sometimes if there might not be an association between iron deficiency and the use of those, because the chemistry of it is the iron has to be in a particular ionized state to be absorbed, and it only gets there in the presence of acid. So that's one place, is if the stomach is messed up. The liver produces the proteins that grab the iron and move it around the body. So when your liver is sick, those proteins don't get made. So even if iron is in your diet, it can't get to where it needs to get, which is to the red blood cells. So that's an iron delivery problem. The diagnosis, as we said, is low levels of hemoglobin, hematocrit. The MCV, that's the size of the cell, mean corpuscular volume, is low. And the MCH, mean corpuscular hemoglobin, that's hypochromia. There's not enough hemoglobin in that cell. And then when we get the serum ferritin, iron, and transferrin, that can tell us where the iron problem is. If the ferritin and transferrin are normal, but the serum iron is low, that suggests that it's a dietary problem. Whereas if the transferrin and ferritin are low, that says it's a liver problem. So two advanced diagnostics, I think, for this class, but this is sort of the standard anemia workup if we're concerned about iron deficiency. All right. So, iron deficiency, well, how do you fix it? Well, you give extra iron, right? And that's generally what ends up happening. Now, you have to identify or try to identify if there's an ongoing blood loss. But if there's not, then you just assume it's a dietary iron deficiency, and you treat it with iron supplementation. Now, iron supplements are in some ways problematic all by themselves. Iron irritates the GI tract. For a lot of people, they'll say, I can't take iron, it causes constipation. So clearly that has to be an effect of iron on the gut. It should certainly be taken with food. Iron is in fact a mineral. You want to dilute it down with something and not just let it sit there because it'll cause GI upset. Liquid supplements will stain teeth because iron is very reactive with lots of different things, including the fluoride in our teeth. So you give it with a straw, or if you're dealing with babies or little kids, you instruct the parents to put it way back in the back of their mouths in a dropper, squirt it down that way. You don't want it on the teeth because it'll stain them orangish brown. And then iron supplementation is not the greatest option for all these reasons. So you want to counsel the patient in increasing the amount of iron in the food that they eat, because then you can get them off the iron supplementation. So, these are things like green leafy vegetables, red meat has iron in it. Those are the two big ones. Darkly colored things, that's what iron looks like out in the environment. All right, so that's iron deficiency. One of these, too few red blood cells. And red blood cells that don't have enough hemoglobin. All right. Another one is megaloblastic anemia, which is also called pernicious anemia. So red blood cells are produced in the bone marrow from cell division, right? It's a stem cell process. When there's no vitamin B12 around, that process doesn't finish. So you end up with red blood cells that are immature. They're big, that's why they're called megaloblastic. They're big red blood cells, but they don't have enough hemoglobin in them, and they're not done maturing, so they don't carry oxygen very well. So vitamin B12 is related to this megaloblastic anemia. Now, specifically, pernicious anemia refers to a very specific disorder, which isn't necessarily clear in my notes. So you may want to add this. Pernicious anemia equals no IF, no intrinsic factor. Intrinsic factor is a peptide that's produced in the stomach that binds vitamin B12 in the stomach, and then the intrinsic factor plus vitamin B12 are absorbed into the body in the distal ileum, so in the terminal ileum. So by definition, pernicious anemia and megaloblastic anemia are not synonyms, which I may have only very recently learned myself. Pernicious anemia is one cause of megaloblastic anemia, which is vitamin B12 deficiency anemia, if all that hopefully makes sense. But pernicious anemia is no intrinsic factor, which leads to decreased B12, which leads to megaloblastic anemia. Okay. So how does that happen? Vitamin B12 is necessary for DNA synthesis. So if the DNA synthesis is messed up, then the cells don't divide correctly, and you get these large nucleated cells that are fragile, so they end up popping, and they don't contain enough hemoglobin either. So that's the B12 deficiency. The common causes for B12 deficiency are inadequate intake and then intrinsic factor problems. So B12 deficiency. The causes there are inadequate diet, so inadequate dietary B12. B12 is kind of a unique vitamin because it is only found in animal sources. So in your extreme vegan, for example, they can actually get into, over the long term, B12 deficiency. And that's because you can get B12 in animal products. In other words, you don't have to eat meat, but eggs or milk, or you're going to get into a B12 problem. So that's a rare cause there. So inadequate intake, malabsorption, and then no IF, no intrinsic factor. Okay. Typically, the malabsorption problem is an intrinsic factor problem. So, some people have had their stomachs removed, either for weight loss management or because they have had cancer or something like that. No stomach means no intrinsic factor. No intrinsic factor means no B12, because the only way that B12 gets into the bloodstream is using that intrinsic factor pathway. So a stomach problem will cause that, or a terminal ileum problem will cause that. Let's say you had Crohn's disease and you had the last part of your ileum removed as part of treatment. You also will have no B12 because you have intrinsic factor, but it can't get absorbed. It's only absorbed in that one place in the terminal ileum. So intrinsic factor, B12, stomach, and terminal ileum all go together under B12 deficiency. All right. So signs and symptoms, these are classic B12 deficiency things. So an enlarged red, sore, and shiny tongue. Decreased levels of gastric acid, that suggests a problem with the stomach, which is, remember, pernicious anemia is intrinsic factor deficiency. And then you'll find those megaloblastic red blood cells, so the classic B12 deficiency anemia. All right. So if the problem is no intrinsic factor or inadequate dietary intake, well, what do you have to do? You have to get more B12 into the patient. If they have a normal stomach and a normal terminal ileum, you can give B12 by mouth. So it's a very common part of like a multivitamin pill. So typically, vegans, vegetarians in America, they take some vitamin supplements anyway. So they usually get their B12 that way and they never get into trouble. But if you had an extreme vegan who refused to take vitamins of any kind, you're going to have a problem. So you have to, you have to talk it through. With them. Let's see. If you don't have intrinsic factor, all the by-mouth B12 in the world will never get into your bloodstream. So the only choice then is by injection or sublingually, which works enough in some people to get the B12 levels back to normal. All right. These are the megaloblastic cells. So this is looking like although it's too big, but see how this has a little nuclear fragment in it here and here? And instead of the nice, crisp little red blood cell disc that you're supposed to see, they look kind of floppy and kind of pale and fragile. These are megaloblastic red blood cells. This is a pretty normal-looking red blood cell right here. So is this one. But these guys are too big, too floppy, and you're not supposed to have nuclei parts in a red blood cell. Anybody know what that is? Pop quiz. White blood cell, good. Which kind?
It's got lots of.
Yeah, it's got lots of nuclei. That would be a neutrophil, an activated neutrophil. Anyway. Okay, so too few red blood cells. So we talked about iron deficiency, B12 deficiency. The last one is simply aplastic anemia. Aplasia means not making. Plastic is to make or to form. That's how plastic from our water bottles got named, is because you can form it into anything. So aplasia is not being made. So in aplastic anemia, the problem is the bone marrow. You know, the bone marrow produces red blood cells. So if the bone marrow is sick or stalled, which is kind of the case in most aplastic anemia, if you're not making red blood cells are dying every day. So as soon as your bone marrow stops making red blood cells, you'll start to become slowly and steadily more anemic as more of your red blood cells die. So sometimes aplastic anemia only has to do with red blood cells, but it can also be associated with pancytopenia. In other words, not enough red blood cells, white blood cells, or platelets is pancytopenia. All of those things are made in the bone marrow. So anything that suppresses the bone marrow can trigger this. So aplastic anemia can be temporary, more common, or permanent. Big problem, you know, if your bone marrow has stopped producing blood cells, period, you know, you are going to have a major problem on your hands and will need a bone marrow transplant of some kind. The typical, so about half the cases, middle-aged, idiopathic cause. So these are diseases that we just hate because you don't know who it's going to be and you don't know why, but every once in a while you'll have an otherwise healthy middle-aged person come in profoundly anemic, and it's because their red blood cell count is in the drink, and it's because of aplastic anemia. So we call that primary aplastic anemia. Theories abound. One is it's a virus caused by a virus because there are other kinds of viruses that cause this. But ultimately, these patients recover, but they may need blood transfusions until their bone marrow wakes up. That's why I said sometimes it's like the bone marrow has stalled. You know, it just stops making red blood cells for whatever reason, then comes back on. There are many different myelotoxins. Myelo always refers to bone marrow. So whenever you see that, a myelotoxin is a toxin against bone marrow. So these are things, radiation, industrial chemicals, certain medications. So if you have an aplastic anemia, you kind of have to search through the patient's history to see if there's any possible causes. You know, does this person work at a chemical industrial plant? Does this person have any exposure to radiation? You know, do they work in a dentist's office where there's an x-ray machine that might be on the fritz and irradiating people? So you have to really kind of be careful going through their history. Certain viruses can cause this. Hepatitis C will do this, not all the time, but in some people it will. Lupus can attack the bone marrow and result in an aplastic anemia. And then certain genetic abnormalities, which we'll talk more about those two at another time. All right. So the symptoms are the same as all anemias, because remember, the symptoms of anemia come from the oxygen-carrying deficit. So the body is basically starving for oxygen. So you see the same symptoms as you do with any kind of anemia. But you may also see effects of leukopenia, not enough white blood cells, and thrombocytopenia. So leukocytes are infection-fighting cells. So if you're leukopenic, then you're likely to get infections, more infections and stranger infections, so that can be a sign. Thrombocytes or platelets are important in hemostasis, or keeping the blood in the vessels instead of leaking out at every little bruise. So a thrombocytopenic person will have easy bruising, easy bleeding, and it can be a sign that it's not just the red blood cells that are affected, but the white blood cells and platelets too. Ultimately, the diagnosis can only be made with a bone marrow biopsy. Take a piece of the bone marrow, look at it, see if it is in fact suppressed or if there's some other reason why the patient is anemic. Yeah?
What is pancytopenia?
That's, penia is too few, pan is all, so that's too few of all the blood cells. So that's leukopenia together with thrombocytopenia and anemia. All together are pancytopenia. As I said, a blood transfusion might be required until the bone marrow recovers. Bone marrow transplant can be attempted in these patients if it's gone on for months and months and doesn't seem to be coming back. But again, that requires a very closely matched donor so you don't have graft versus host disease like we talked about the other day. Okay, so that is all this category. Too few red blood cells, or red blood cells that don't have enough hemoglobin in them. So not enough oxygen carrying capacity. The other big group of anemias is this one, the red blood cells dying. So we call these hemolytic anemias. There are a number of infections that can trigger a hemolytic anemia, but your book goes into the two genetic types, so sickle cell disease and thalassemia, both of which are genetic, you're born with them, gene defects that affect the hemoglobin gene itself, so the hemoglobin protein, and both of these cause red blood cells to be short-lived or causes them to be damaged. All right, so both sickle cell, which is SCD, and thalassemia, both of these are hemoglobinopathies, which is kind of a fun word to say, but that's just a problem with the hemoglobin. So it's not a red blood cell problem, really, even though it results in red blood cells dying off at too high a rate. The problem is with the hemoglobin gene itself. So sickle cell disease is results from a single difference in the hemoglobin gene. So it just shows you how genetics can sometimes be a little fragile. One change in that hemoglobin gene of one amino acid for another means that when the sickle cell hemoglobin, or sickle hemoglobin it's often called, when it enters a region where oxygen concentration is very low, it changes shape. Essentially, all the hemoglobin in the red blood cells attach together, so they all bind. And when they all bind, because of the shape of the molecules and the shape of the red blood cell, they end up forming a shape like a crescent moon. That's how it gets its name. You know, a sickle is a rounded blade that you use to cut wheat or corn. So it forms this sickle. Now you can imagine that this red blood cell with its pointy ends now is not going to travel through the blood vessels very easily. It's going to end up getting stuck on stuff. They're going to get stuck to each other. It's going to jam up against the walls of small vessels. And that explains a lot of the symptoms of sickle cell disease, is these cells, not only do they break, causing an anemia, but they get clogged into stuff. So sickle cell disease is fraught with infarction, both mini infarction and macro infarction. Infarction is just where an artery is clogged up and what the tissues distal to that artery don't get any oxygen, don't get any nutrients. So sickle cell disease often has episodes of pain throughout its course until the patient dies of other causes. And it's from sickling cells blocking blood vessels. But the anemia part is caused by their fragility. Sickle cell red blood cells are fragile. So instead of living 120 days, they live 20 days, so 1/6 the lifespan. So what that means is their bone marrow has to produce 6 times as many red blood cells as a normal person's bone marrow would have to produce. So it's a challenge. And because of that, the bone marrow can never quite keep up with the increased destruction, and they end up with a very low red blood cell count. And because and low hemoglobin concentrations as well. All right. So sickle cell, they cause infarctions, which causes multiple pain crises. The spleen is particularly at risk. The spleen has more little nooks and crannies of vessels than any other place in the body. So these sickle cells end up getting clogged in the spleen, blocks the blood supply to parts of the spleen, a little bit over time, and eventually the spleen is destroyed by these constant infarctions. So a patient with sickle cell disease who's older than about 10 years of age, we consider them to be asplenic. We consider their spleen is probably destroyed, and we treat them as such. So like we'll give antibiotics with dental work and things like that. So because the sickling is triggered by deoxygenation, anytime the patient has an oxygen issue, so let's say they have a pneumonia. In the normal patient, okay, a pneumonia reduces oxygen concentrations, but it still is well within, a patient's tolerance. In the sickle cell patient with pneumonia, it sets them into a massive sickle crisis because all over the body now, these cells are sickling because the trigger to go from normal red blood cell to sickle cell is a drop in oxygen concentration. So in the sickle cell patient, respiratory illnesses are taken incredibly seriously. We want to put oxygen on those patients as quickly as possible, get them started on treatment as quickly as possible. A particularly nasty combo is asthma and sickle cell disease because asthma has periodic times of deoxygenation, asthma attack, which then leads to the sickling and the pain, which then gets the patient anxious, which makes the asthma worse, and it can be one of those vicious spirals. I treated lots of kids with sickle cell disease. So here's just that in pictures. Normal red blood cell, this is a sickle cell patient's red blood cells. When the oxygen level is normal, they function normally. They carry oxygen like they're supposed to. The problem is when they get somewhere where the oxygen level is low, which there are places in the body where that happens from time to time. If you are busy exercising, for example, your digestive tract gets a little hypoxic because blood's not being sent there. It's being sent to your skeletal muscles instead. So any place that the oxygen level is low, we get the classic sickle shape. That causes them to break open or hemolyze. It also causes them to stick together and block arteries. And then once they block an artery, you're going to get pain distal to that because there's no oxygen flowing there. So sickle cell disease sort of in a nutshell. In addition to having a severe anemia, they also tend to have a little jaundice. So the whites of the eyes of the sickle cell patient usually have a little yellow tinge to it. And that's because these breaking open red blood cells, the hemoglobin is still going to be recycled, so the bilirubin is going to be made, the iron is going to be stored in the liver, but the body can't make them as fast as they're breaking. So you end up with a high bilirubin as that hemoglobin sort of gets stuck in the recycling process. All right. It is autosomal recessive, so you have to have 2 sickle cell genes in order to have sickle cell disease. Otherwise, you're a carrier, what they call sickle cell trait, but not disease. The carrier population is quite high in Africa and in people of African descent, and there seems to be a reason for that. People who have sickle cell trait but not sickle cell disease, in other words, they have one sickle gene but not the other, they have an increased resistance to malaria. So the reason that this gene probably exists, even though it causes this terrible illness in the homozygous or in the affected patient. In its heterozygous state, it's protective, which is probably why the gene, was put forward generation after generation. All right. It is not only seen in people of African descent, though. There is sickle cell disease in people of Middle Eastern descent, as well as some other, Pacific Islanders, for example, some other scattered populations. But typically, the typical board question is somebody of African American descent or African descent. All right. So the signs and symptoms, you don't see anything until after age 12 months. And that's because in the infant from 0 to 12 months, they are still making fetal hemoglobin. And we're not going to get into this in much detail, but the fetus's hemoglobin is different than the adult's hemoglobin, and that's because the baby has to be able to grab oxygen, has to be able to steal oxygen from mom's hemoglobin. So it has to be different. If it was the same, mom's hemoglobin would keep the oxygen and baby would never get any. So we have this fetal hemoglobin that is more aggressively grabs oxygen than the adult variety. But after that age 12 months, then you start getting the classic signs. So severe anemia, pallor, weakness, tachycardia, dyspnea. Hyperbilirubinemia, that's from the increased turnover of hemoglobin from these cells breaking, causes jaundice. In the older sickle cell patient, gallstones also go with that because they dump more bilirubin than the normal patient does. Early on, the spleen gets big, and it gets big because it's being basically clogged up. So you get vascular congestion. Eventually, you get necrosis or infarction, and by adulthood, the spleen is small and all shriveled up and non-functional because it's all died off. What you see these patients come into the hospital for are what are called sickle cell crises. And this is where, for whatever reason, there was enough deoxygenation that these sickle cells started clogging up arteries in various parts of the body, and it leads to pain. Now, one of the big problems that these patients have is they experience bad pain frequently over their lives, so they end up getting pain medicines to deal with that pain, and they're at very high risk for opiate addiction because of that, because they end up needing opiate medicines frequently over their lives. So it's something that the hematologists that treat these patients are always very careful about because they've seen way too many patients go the path of illegal drug use and all that from opiate addiction. So both kids and adults both are often treated inpatient for pain management. Probably the worst case thing that can happen to you is what's called acute chest syndrome. And this is a vicious cycle where the infarction from the clogged up sickle cells are in the lungs. So if you infarct the lungs, you're going to lower the oxygen concentration in the whole body, right? Because there's not blood flowing past the oxygen. So you have that infarction, which leads to inflammation, which leads to deoxygenation, which leads to more sickling, which leads to more infarction in other places of the body or even in the chest. And patients can die of this because it's a downward spiral. The less oxygen there is in the body, the more sickling there'll be, the more occlusion, the less oxygen, and then so on. Hand-foot syndrome is where the occlusions are in the hands or feet. This can occur in the cold weather when vasoconstriction occurs and oxygen concentrations drop in those places. In the older sickle cell patient, congestive heart failure can result because the decreased oxygen carrying capacity means the heart has to work harder all the time. It has to pump the blood faster. It has to beat more. So you can end up with what's called a high output heart failure. And then the frequent infections that go with the absence of the spleen. All right. So we're going to stop right there because we're right at time. But we made good progress through that. So we'll talk about how they treat sickle cell disease next time, and then we'll do thalassemias, and then we're going to move ahead into the cardiovascular stuff.